Okay, good day, everyone. Today, let's discuss ERPM pediatric past paper. I'll be discussing more than 10 past paper at least in each subjects. And also, they are I have prepared all these past papers by combining SBA's single best answers together and true or false together like that. And I'll be providing the paper as well. And it's important to practice more and more MCQ papers so that you can easily clear your theory now because according to all new format, it is mandatory to get more than 25% in all your papers in any attempt. If you get less than 25% in any of the paper, you have to sit for all the subjects again, even if you pass any of the subject. Okay, so take that in your mind and study. So here I will advise you to practice and study for ERPM exam from your third year and fourth year onwards because once you graduated from your university, you have to sit for the ERPM soon. So, and according to new format, you have to pass all the exams in one attempt. It's not mandatory actually, but you have to take more than 25% in any attempts. Okay, so for that purpose, you have to study from your third year and fourth year onwards. And if you study like that, it would be easy because in ERPM exam, you will be assessed mainly on the management done in Sri Lanka, not in the about the management done in any other countries. So you have to be thorough with it. So for that, if you need to practice that, you have to study but the things, the Sri Lankan management from your third year and fourth year onwards. They won't ask the deep, they won't assess the deep knowledge. They will ask superficially. Okay, and you have to have a superficial wide knowledge in your clinical practice and also your theory. Okay, they won't ask the deeper things. Okay, so don't study the uncommon things. Definitely they will ask about the common diseases, common clinical presentation in Sri Lankans. Okay, but sometimes one or two MCQs might appear in uncommon things, but that's okay. But the common things are always common. So practice and study the common things first. Okay, let's discuss the MCQs. This is a single best answer type where you will be given 5 answers and you have to choose the best answer. Okay, for that you have to clearly read the question because sometimes they will ask what's the first management. Sometimes they will ask what is the best management. You have to know the difference between first management and best management. First management means the life-saving one. The best management means that's a definitive management which should be given to the patient. Okay, so carefully read the answer, carefully read the question and answer, and you have to practice doing the MCQ within a time given. Otherwise, in your exams, you won't get much time and you will get tensed and you will lose all the MCQs you know as well. Okay, for that, practice the papers again and again. More you practice MCQs, more you can score. And always remember that without theory knowledge, you can't do the MCQ. For that, please do refer my notes I have given. I have given the notes in a short way, which is needed as a Sri Lankan undergraduate level. Okay, that is more enough to get distinction for the Sri Lankan undergraduate level. Okay, go through my notes and recordings for that. Anyway, I'll be discussing all the clinical oriented the notes and the MCQs, OSCEs according to new format. So you can access all of that once you got access. Okay. A 2-year-old boy when you're reading the MCQ, you have to note the key words in question, because you don't have much time to read the question again. So when you're reading for the first time, mark the keywords. Okay, then it would be easy for you. The 2-year-old boy was brought with 2-week history of fever and poor weight gain. Examination revealed significant pallor, cervical lymphadenopathy, and abdominal mass. Was a feature that favors diagnosis of neuroblastoma. Okay, here the keywords are the age of the child, sex of the child, and he is having 2-week history of fever and poor weight gain as well. Okay, only for 2 weeks, and there's a significant pallor. Pallor means it depicts that he has anemia. Okay, and also there's a lymph node enlargement, lymphadenopathy. And there's the abdominal mass. You don't know what's the abdominal mass could be. But for undergraduate level, there are 3 chances for undergraduate in pediatrics. Okay, it could be hepatomegaly, enlargement of the liver, or it could be splenomegaly, enlargement of the spleen, or any type of malignant mass. It could be anywhere in the abdomen. Okay, so from this, what is the feature that would diagnose a neuroblastoma? They are not asking the diagnosis. Okay, the diagnosis is already given. Out of these 5 features, what is a characteristic feature for neuroblastoma? That is the question here. Okay, so cervical lymphadenopathy can appear in any of the malignancy, even lymphoma. So it is not a characteristic key feature of neuroblastoma. What is neuroblastoma? Neuroblastoma is a childhood tumor that occur in the sympathetic nerve system chain. Okay, so it could appear in the adrenal gland, sympathetic chain in the neck, or mediastinum, or in the retroperitoneal organ. That's a neuroblastoma, tumor in the sympathetic chain. Okay, so it's a most common extracranial solid tumor in children. So those are MCQ points. So refer my oncology note for that. All the points are there. So it is often aggressive tumor, and usually the children presents with metastasis. Usually it metastasizes to bone, lung, bone marrow, liver, and there are sometimes this neuroblastoma is associated with syndromes like Bloom syndrome, Beckwith syndrome, like that. But if the child, even though it is aggressive tumor, if the child is less than 18 years, the response to treatment is still good. Okay, the child will be presenting with cachexia, the pale anemia, febrile pain, and usually for the diagnosis we use true cut biopsy. So these are the characteristics of neuroblastoma. So cervical lymphadenopathy is not a characteristic feature, because lymphadenopathy can appear in any malignancy, any tumor. The mass crossing the midline. Okay, so mass crossing the midline means it's a tumor which appear in the sympathetic nerve system, the sympathetic chain. So once it appear in the chain, it can cross the midline, it can grow and cross the midline. So it could be a characteristic feature. I have these features are common MCQ points. I've given that in my note as well. Poor weight gain, it can be a symptom in any of the disease, not only in malignancy, but also in any infection or any failure to thrive, MAM-SAM, any disease or any condition, there could be poor weight gain. So we can't say it as characteristic feature. Prolonged fever also, it means pyrexia of unknown origin, or it could be a feature of malignant and non-malignant diseases as well. So we can't say it as a characteristic feature. And significant pallor means a significant anemia might occur in any of the disease, not only in malignancy. So the answer is mass crossing the midline. So when you're doing the MCQ, even if you don't know the subject, still in single best answer, it won't carry a negative marks. Okay, so if you get correct, you will get 5 marks. If you are wrong, 0. There is no negative marks, because you are going to mark only one answer here. So don't skip any SBA, single best answer, without answering, because even if you don't know the answer, even if you mark by luck, you might get it correct. Okay, so here, even if you don't know about neuroblastoma, you can go through the answers. Okay, and you can work out, okay, poor weight gain. In which diseases poor weight gain might occur? Okay, there are many diseases. Prolonged fever, many diseases. The prolonged fever can occur like that. Work out and try to get the answer. Okay, don't skip any single best answers, because you don't have negative marks. I'm again and again emphasizing this point. Don't skip. Okay. Okay. Then the next question. 4-year-old girl presents to the emergency department with 3-day history of left-sided weakness. Okay. So left-sided weakness, so it could be related to a brain. Like that, you have to work out. Okay, if there's a weakness, the symptom. So if there's a shortness of breath, the system related mainly heart, lungs, like that. If there's a weakness, usually the related systems are the brain. Okay. On physical exam, she has a temperature of 99 degrees Fahrenheit, 37.2. Okay. It's not, she has fever, but it's not a significant fever. There's a low-grade fever. Okay. Pulse of 50 beats per minute. Okay, here in pediatrics, you can't take the adult value as a cutoff, because for any pulse rate, respiratory rate, blood pressure, everything, there's a cutout for age. Okay, you have to know that for exam papers. They won't give it in your exam paper. So for blood pressure, there are centered charts. According to the height and age of the child, blood pressure is measured and it is plotted. So any value between 5 to 95th centile is considered as normal. Okay, in blood pressure. So and for pulse rate, I have given this in my asthma note. Go through this value, and I have given all the charts, but you don't need to memorize the charts. If you have rough idea, that is enough to do the MCQ. So if the child is less than 5 years, the respiratory rate should be less than 40, and the heart rate should be less than 140. And between 5 to 12 years, the respiratory rate should be less than 30, and heart rate would be less than 125. This is the cutoff in Sri Lanka. Okay, so here temperature is a bit high and pulse rate is 50. It is bradycardia because it is far more less than usually the normal heart rate should be less than 114, less than 5-year-old child. But the 50 is very low. So it is bradycardia. And the respiratory rate is 24. So in a 5-year-old child, respiratory rate should be less than 40. So 24 is a bit okay. But the blood pressure is 118 by 78. This is not normal for blood pressure. Okay. But the systolic should be between 88 to 112 millimeter mercury. And diastolic should be 50 to 72 millimeter mercury in a child less than 5 years. Okay, in a child, actually a 4-year child. Okay, so here the blood pressure is bit high. So the child is having bradycardia and hypertension. Okay, so first, without finding that, you can't go through, you can't get the correct answer. Okay, she can't abduct her right eye. Right eye also affected. That's a neurological deficit and has normal fundoscopic examination results. So there is no increased intracranial pressure because fundoscopy is normal. Okay, but still we are not sure whether there is increased intracranial pressure because she has admitted to the emergency department. So there's a neurological deficit, but fundoscopy is normal. Strength on the left side is the tone of the muscles in the left side is 4 by it's at reduced in the upper and lower extremity on the right, and on the right it is normal. On the following, which of the following is the most appropriate next step in the evaluation of this child? So here they have asked the next step of management. Okay, it could be a investigation or it could be a drug or treatment. Okay, so here Our main concern, because the child has presented to the emergency department. So out of this, she's having some neurological deficit, okay? And she's having bradycardia and hypertension. But still the respiratory rate is normal. So we have to look for that. You all know hypertension and bradycardia, a sign of Cushing syndrome. So you have to look for whether there is increased intracranial pressure. They have already done fundoscopy examination, which is normal. So you have to be 100% sure whether there is any space occupying lesions. For that, the next step of investigation we do in Sri Lankan setup is CT, computer tomography scan of the brain. You can do cerebral angiography, electroencephalopathy, positron, signal, all those things, but they were useless because you can't exclude the space-occupying lesion by doing other investigations. So in positron tomography, single photon emission, these are not routinely done in Sri Lankan setup, okay, unless there's an indication. And usually most of our government hospital, they don't have this facility. Okay, so CT brain, we are doing the CT brain to look for the increased intracranial pressure. And angiography is usually done to look for the site or vessel which is involved when there's any neurological deficit. So the next best management is doing CT to look for any space occupying lesion, because there are neurological signs. Neurological signs, which means the brain parenchyma and meninges are affected. So it could be due to a compression. Okay. Okay, the next question. 2.5-year-old boy had been born at 29 weeks. She's preterm, okay? A gestation at 0.96 kg, the birth weight. He can now understand simple instructions and speak using 3-word combination. He can sit unsupported, can feed himself, can stand, but he can't walk unaided. Okay, this is the only issue in this child, the developmental issue. But the most likely diagnosis. So here the answers are, there are many types of cerebral palsies are given, and the global development delays are given. So here the problem is, for he's 2.5-year-old, so preterm. Do we need to age correct to assess the development? No, the age correction is only up to 2 years. So he's 2.5 years. So we can directly compare this child with a 2.5-year-old term baby. Okay, so 2.5 years, you have to know what are the developmental milestone the child has to attain. Okay, for that, refer my developmental assessment chart. All the things are there. Okay, so in 2.5 years, there are 4 main domains in gross motor, vision, hearing and speech, and social. For gross motor, the child should be able to run well, walk upstairs. He could be able to jump in 2 feet, stand tiptoe. He could be able to kick the large ball. These are the gross motor development for 2.5 years. And in vision and things, he could be able to imitate a straight line or a circle. He could be able to build up a tower of more than 7 cubes. He could be able to recognize himself. Okay, there's no issues in vision here. And in hearing and speech, he could be able to speak more than 200 words. Okay, so here he is speaking 3-word combination. So the speaking also normal. And he could be able to ask questions, he could be able to tell rhymes, running commentary, names of the people. Okay, so here the speech also normal. In social development, he could be able to feed with spoon, might be dry by night, and pulls down pants when he's using toilets. Okay, so social also normal. Here the only issue is he can't walk without an aid. So there's the issue in the gross motor development. So you can't cut this global development delay, because in global development delay, there should be more than 1 mile, the impairment in more than 1 milestone. Here only gross motor is impaired, but all other domains are normal. So it is not global developmental delay. Okay, and there is no developmental coordination disorder as well, because there should be there are more than one domain. One domain, it means gross vision, speech, social. Out of 4, there should be more than one. So B and C won't come. And other 3 answers are types of cerebral palsy. Okay, so you have to know the types of cerebral palsy and their presentation. I have given all those things in my cerebral palsy note. Go through that. In athetoid cerebral palsy, it is an extrapyramidal. The issue is in the extrapyramidal area. And the spastic mean increased tone. This is a cause, this is a 80% of cerebral palsy is spastic cerebral palsy. So diplegia means the lower limbs are affected more. Okay, the upper limbs are not affected or less affected. Quadriplegia means all 4 limbs are affected. Hemiplegia means half of the body is affected, half side, both upper limb and lower limb. Okay, here the upper limbs are quite normal. The issues are in the lower limb. So it could be spastic diplegia. Okay, so in any spastic cerebral palsy, there could be upper motor neuron signs such as spasticity, where tone is increased, deep tendon reflexes increase, extensor plantar response, clonus, Babinski signs could be positive. Those are the signs of upper motor neuron lesion, signs of any spastic cerebral palsy. But athetoid cerebral palsy is due to brain asphyxia. So there could be global ischemia. Global ischemia means total body is affected. Initially, there won't be upper motor neuron signs in athetoid cerebral palsy. Then with age, the child will develop increased tone. Okay, so in diplegia cerebral palsy, there could be scissor gait because the tone of the hip adductors are increased. So the all over limbs will be crisscrossed like a scissor. Okay, and in hemiplegic cerebral palsy, the child will be having circumductive gait because the flexion of the affected side is reduced, so it requires swinging of the leg outwards. Okay, and there could be early handedness. Usually around 18 months, the child develops handedness. Handedness, it means a right-handed or left-handed. They will use more. But before 18 months of age, if the child is using only one side of the hand, it is known as an early handedness, because in hemiplegia, half of the body is not working. So the child will be working with the other half, the normal half body. Okay. In quadriplegia, there's a high chance of seizures. It's a severe cerebral palsy because the all 4 limbs are not working. There's a difficulty in swallowing and cognition. There's a cognitive impairment as well. In athetoid, there will be involuntary contraction of all the muscles, but the intelligence is normal and the seizures or the rate also less. But the upper limbs are more affected than lower limb in athetoid cerebral palsy. And there will be difficulty in speech and swallowing. Okay, so go through my cerebral palsy. I have given all these things in a chart. If you know that, then the MCQ will be easy. Okay, the next question. Neonatal deaths are the major contributing factor for infant mortality in Sri Lanka. What would be the most effective strategy to be taken by the Ministry of Health in order to reduce these deaths? Okay, this is a community medicine MCQ according to all format. One question will be in community medicine in pediatrics and psychiatry. And psychiatry MCQ will be there, one MCQ. But according to new, there's a separate paper for community medicine, even though according to old also there was a separate MCQ for community medicine, but still you will get one MCQ. So if you know that, mark it, otherwise leave it. No, you don't need to bother, because there are the MCQ, you can get to them as well. So here, what are the most effective things they can take to prevent the neonatal death? Okay, so to prevent the neonatal death, the children less than 1 month of age, 28 days of old. To prevent neonatal death, you have to give the basement, the correct basement. Without the basement, you won't get the strong building. So what's the basement? So what's the main basement is the pregnancy. If their pregnancy period is strengthened, you can still reduce the neonatal death. So increase availability of surfactants, no, it is not possible because we have lack of resources. And if the child is preterm, actually before age of 36 weeks of gestation, definitely we will give surfactant. But neonatal death means after birth, within 28 days of life, the child is dying. So you can't simply prevent neonatal death by only giving surfactant. Improve perinatal care, yeah. Prenatal care, the pregnancy, the overall, if the overall outcome of the pregnancy is good, we can still reduce the death. So according to that, improvement of the perinatal care is a answer. It could be answer. Antenatal supplementation of folic acid, still it is given, folic acid is given, but only with folic acid you can't prevent neonatal death. You have to give other than calcium, iron, good scanning, good nutrition, all those things has to be there. Strict implementation of exclusive breastfeeding in first 6 months. There's an exclusive breastfeeding, but still, if a mother can't give milk, or if a mother is dead, still the child has to be fed with formula milk. So you can't restrict that. Okay. And strict implementation of national immunization program. Already there's a strict implementation, but still there's a neonatal death. So a proper perinatal care can reduce the neonatal death. Okay, this is the answer. Okay. The next question. 2-month-old baby with a large ventricular septal defect is admitted with poor feeding and coryza for 2 days duration. Her birth weight was 3 kg and her current weight is 4.3 kg. Okay, note the important keywords. Okay, birth weight 3 kg, but now within 2 months she has attained extra 1.3 kg. Okay, on examination respiratory rate is 50 with oxygen saturation 96 and heart rate 170, 20 pulse, pansystolic murmur at the left sternal edge. The liver is palpable 4 cm below the right costal margin. What's the first step here? They have asked the first step, not the best. First step in the management of this baby. So what has happened to this baby? Here, the baby is having ventricular septal defect. Okay, so go through my cardiovascular short case note. I have given all about ventricular septal defect. So she is having the pansystolic murmur. So for undergraduate level, pansystolic murmur occurs usually in VSD and mitral regurgitation. Okay, and there's a 30 pulse as well. Usually 30 pulse. The pulse increases in mitral regurgitation and patent ductus arteriosus. Okay, so here he is having VSD, but he has the child has developed a complication of VSD. So for that, what are the complications of VSD? The main complications are heart failure, pulmonary hypertension, Eisenmenger syndrome, infective endocarditis. Out of these, what is the complication they have discussed in this question? Here, they have told respiratory rate is increased, saturation is low, heart rate is high, and there's a murmur, and the main is liver is pushed down. Okay, liver is pushed down. So they are indirectly they are saying that there's a heart failure. Okay, which is a complication of ventricular septal defect. Okay, so in ventricular septal defects, there are main 2 types, membranous and muscular types. Okay, so in ventricular septal defects, usually in inspection, the child will be small for age and dyspneic if the child is having heart failure. And on percussion, there will be apex will be displaced, and there will be systolic trill in left lower sternal edge, and there could be left parasternal heave, loud P2 if the child has developed pulmonary hypertension. And on auscultation, there could be harsh pansystolic murmur in left lower sternal edge. And you have to know what are the murmurs that occur in the according to the site. Because for undergraduate level, definitely You can't say just by auscultating the murmur because we don't have such experience. Only cardiologists can do that. For that, if you know the types of murmurs that occur in particular sites and their radiation, if you know that, you can say the type of the murmur. Okay, though all those things are given in my CVS short case note, go through that. And if the ventricular septal defect is small, there won't be symptoms and signs. There won't be pulmonary hypertension, no heart failure, and the murmur could be short but loud because the defect is small. So there will be turbulent flow making more sound. So the murmur could be short murmur but loud murmur if the defect is small. Okay, but if the VSD is large or severe, there could be symptoms of heart failure, dyspnea, poor feeding, and inadequate weight gain. And there could be long murmur but soft murmur because the defect is large. So we can't expect more sound. Okay, and then there will be heart failure and pulmonary hypertension. Okay, so here the weight gain is also poor. In 2 months, the child has gained 1.3 kg. Okay, you all know that I have given already in my note the weight gain according to age. From first 4 months, of age, okay, first 4 months of age, the child will get 20 to 30 gram per day. Okay, 20 to 30 gram per day. Child will be increasing, okay, in weight. And from 4 months to 12 months, the child will be gaining 15 to 20 gram per day. And in 5 months, the child will be twice the birth weight. In 1 year, child will be in thrice the birth weight. And in 2 years, child will be 4 times the birth weight. Okay, this is a usual calculation. This can be asking you MCQ. So here, the child is having low birth weight. Sorry, not low birth weight. He has not gained the adequate weight. So there's a failure to thrive as well. So here the complication the child has developed is heart failure. So the management for heart failure is always the first management is diuretics. Okay. So heart failure, you have to look for the diet, growth, and the diuretics are the first line, where furosemide and spironolactone are given. Furosemide is the first line, and also you can give ACI inhibitors. If there's a pulmonary hypertension, we go for vasodilators like sildenafil. Okay, so we have to go for surgical treatment. If the child is having failure to thrive, pulmonary hypertension, associated aortic regurgitation, significant shunt, we might have to go for surgical correction of VSD. If it is small VSD, it spontaneously closes. Okay, so answer is intravenous furosemide. The 100% oxygen, it's not a first step, but you will give 100% oxygen in any time. But the first step is to give the diuretic. Okay, and CPAP, you won't go for the invasive ventilation first. You will give the non-invasive methods, then only you go for the invasive. Okay, the next question, you attended a newborn baby at delivery room. A baby boy has bilateral cleft palate. Further examination reveals scalp defect in the parieto-occipital region. Microphthalmia, the eye defect, cryptoschitism, cardiac murmur, polydactyly. There are many defects in the child. Okay, which are the following the most likely underlying conditions? So by combining all these symptoms, what could be the issue in that baby? Okay, there are many syndromes, but you don't need to know about all the syndromes for undergraduate level for ERPM exam, because in Sri Lanka the most common syndromes are trisomies 21, which is down, 13 and 18. They will never ask about other syndromes. Okay, so if you know about these 3, that is more than enough. So go through my genetic notes and Down syndrome notes. Everything is there. If you couldn't find the points, I have given the illustrated pediatric book and concise pediatric book. Those two are the books recommended for Sri Lankan undergraduate, because MCQ, 100% MCQ will be there in that book, from that book. Okay, if you couldn't find the answer, you can refer them. Okay, in trisomy 30, there it is known as the Pato syndrome. There's an extra copy, trisomy 3. Actually, chromosome contain 2 copies, but in trisomy there are 3 copies. That's the abnormality. There's an extra copy of 13th chromosome. Okay, this is a Pato syndrome. So here, majority of this Pato syndrome is due to non-disjunction, due to increased maternal age. So there could be midline defects in the midline, like cleft palate, cleft lip, scalp defect like cutis aplasia, hollow presencephaly, microcephaly, omphalocele, in the midlines, the midline of the body, from head to toe, there could be defects. Anophthalmia, eye, cardiac defects like ventricular septal defects, renal issues like polycystic kidneys. Those are the things appear in trisomy 30. Okay, trisomy 18 means Edwards syndrome. They are having small face, prominent occiput, loose skin, sloping forehead, and tetralogy of Fallot can be there, and rocker bottom feet. So there is no defects given according to the feet, the legs. So it's more towards the Pato syndrome, which is trisomy 30. That's the answer. And valproate embryopathy main, it's due to mother using sodium valproate during pregnancy. Sodium valproate, the drug, the epileptic drug, is contraindicated in pregnancy, but if a mother uses it accidentally, the child will develop maxillary impairment, wide eyes, hyperplastic toenails, hyperplasia of the limbs, and thin upper limbs. Okay, so this child, it moves towards Pato syndrome. Okay, go through the Down syndrome note as well. Okay. Okay, the next question. 5-year-old boy presented with abdominal distension jaundice for 3 days duration. On examination, liver is palpable 6 centimeters below the causal margin. So there's a hepatomegaly, but there is no splenomegaly. Here, sister also having some sort of abnormalities. So, okay, if siblings or any family members are spoken in the question, think they are going to discuss about a genetic condition, okay, or a familial condition. Okay, these are the keywords. If other family members are spoken in the question. Okay, so here they have spoken about his sister. Sister is 12 years and she is having learning disability, tremors, and dysarthria. Okay, so she is having an abnormality in the brain. This 5-year-old boy is having abnormality in the abdomen. He's having jaundice, hepatomegaly. Okay, investigations reveal there's an elevated total bilirubin and liver enzyme. So definitely there's a liver impairment in that 5-year-old child. What's the most likely diagnosis? Okay, these are the diseases related to the liver. But here, note, here there's a familial involvement as well. So you have to find out of these 5, which disease has familial involvement, it means genetic, and affecting more than one system, because the child is abdominal system is affected, but the child sister's brain is affected. So it is affecting more than one system. Okay, so for that you have to know about these diseases. Okay, you don't need a deep knowledge. So in what is this glycogen storage disease? Okay, so in if there's a jaundice and abdominal distension, usually the differential diagnosis mainly systems based hematology, the blood and the liver. If there's a tremors, dysarthria, the brain is involved. So you have to think, they have to narrow down your diseases like that. What are symptoms, systems involved, and then only you can go for the answer. So glycogen storage disease, refer the concise book, the liver diseases. Glycogen storage disease, there's an impairment in the metabolism, there's a abnormality in the metabolism of storage of glycogen. So there is no there's a lack of glycogen in the body. So glycogen is important for the muscle. So the child will be having muscle weakness, cardiomyopathy, hypoglycemia, failure to thrive, hepatosplenomegaly. But there is no such brain involvement. Okay. So it is not glycogen storage, and there is no familial involvement as well. Hepatitis B, in hepatitis B infection, the child will be having jaundice, fever, tender hepatomegaly, splenomegaly, ascites might be there. The jaundice will be very deep jaundice with dark urine because the liver is affected. And he could present with chronic hepatitis, acute hepatitis, or hepatocellular carcinoma due to hepatitis B infection. So there is no such familial involvement as well, and brain involvement, so it is not hepatitis B. Autoimmune hepatitis, it is a T-cell mediated autoimmune disease. It is common in older child and adolescents. So here, that's why I have told initially, every word here in the SBA are keywords. Here it is 5-year-old boy. So it is unlikely to be autoimmune hepatitis. Okay. And there are characteristic, the features of autoimmune hepatitis are increased transaminase, increased immunoglobulin level, and there will be positive autoantibodies in autoimmune. They have not given such the characteristic features in this MCQ, so it's not autoimmune hepatitis. And SLE, systemic lupus erythematosus, there could be neuropsychiatric symptoms, yes, mucocutaneous symptoms, renal impairment, hematological impairment, but the liver involvement is less, and the age is not also is not appropriate. In 5 years, usually SLE won't appear. They usually appear in the young adults, especially girls. Wilson. Okay, what is Wilson? Wilson means there's a mutation in the formation of ceruloplasmin, which transport copper. So copper will not be excreted out. It will be accumulated in various organs. So it's a mutation. So it's a familial genetic thing. Okay. So copper will deposit in any of the system, any of the organ. The common organs involved are liver, basal ganglia, kidneys, cornea of the eye. So there are two main phenotypes in Wilson's, which is needed for the undergraduate level. There's hepatic phenotype which is predominant in the young children, and there's a neurological phenotype which is predominant in the adolescents. Okay, so the neurological phenotype is in the 12-year-old her sister, and hepatic phenotype is in this baby. So the answer is Wilson disease. Okay, that's why I'm telling the theory knowledge, the notes I have given is very important, because they won't repeat the same question, but they will repeat the same area. Like that, if they have asked about Wilson, they might give you a true or false MCQ regarding Wilson's in your next paper. So for that, you have to know everything, not everything, I mean wide knowledge in Wilson. If you go through my note, that is far more enough to get distinction. Okay, so read about Wilson in my note. Okay, the next question. 4-year-old boy presented to the clinic for evaluation of poor growth. He is on normal adult diet, but continues breastfeeding. 4-year-old. Okay, is it abnormal to continue breastfeeding in 4-year-old? No. But exclusive breastfeeding only for up to 6 months. But structured breastfeeding can be given up to any age if the mother is producing milk. Okay. He had 2 episodes of diarrhea in the past. He is healthy and development also normal. The weight for age is between +1 ST to -1 ST. It's also normal. Height is below -3 ST. Okay, he is short stage. It's abnormal. Weight for height is between median and +1 ST. It is also normal. So what's the reason for his growth problem? Okay, here go through my short stature note. Here the child is having short stature. So how do you know the child is having short stature? Short stature means if the height of the child for age, if it is less than -2 ST of mean age, here the child is having -3, so it is less than -2. Or if the child is having more than 2 ST below the mid-perineal height, also short stature. If the child is having growth velocity less than 5 centimeter per year, 6 months apart, the two readings 6 months apart, that is also known as short stature. So you have to know what is short stature first. Go through my short stature note. Okay. Here, the child has experienced 2 episodes of diarrhea. It's an acute thing. It's not a chronic thing. And development normal. The only abnormality here is the short stature. Okay. Usually height depicts the chronicity. So there should be a chronic problem. Okay. A problem for long time, which has led the child to be short stature. Prolonged breastfeeding is not a cause, because prolonged breastfeeding, unless it is exclusive, if it is structured breastfeeding, that is okay. That's not a problem. Long-standing neglect. So if there's a neglect, there could be problem in the weight of the child as well, but the weight is normal. So it is not due to neglect. Inappropriate diet, there could be problem in both height and weight, but only height is affected here, so it's not a issue. Infection, due to infection, only acute, it's an acute condition. So child will experience weight poor in the poor weight gain, but not the height, because height depicts the chronic, the prolonged, the long-term problem. So the issue here is growth hormone deficiency, because you all know growth hormone is important for the height of the child. So the answer is growth hormone deficiency. Okay. So in any child presenting with short stature, you have to look for the dysmorphic feature, whether there is any endocrine abnormalities or whether there is any gastrointestinal abnormalities. Then only you can go through the investigation. So go for that. Refer my short stature note. I have given the flow chart. Okay, the next question. 2-year-old child is brought to the emergency department with the convulsions following diarrhea illness. Okay, after diarrhea, that's a convulsion. Okay, so his hemoglobin is 7. He's anemic. Platelet also 80. Thrombocytopenia. While in hospital, he is noted to have systolic blood pressure persistently greater than 120. It's the 90 percentile 110, so it is high systolic hypertension. Okay, urine analysis is positive of hematuria. He's having hematuria as well, and proteinuria. What's the most likely diagnosis? Okay, after diarrhea, the child has experienced all these symptoms. What are symptoms? Here, convulsion, anemia, thrombocytopenia, increased systolic blood pressure, hematuria, and proteinuria. Hematuria, proteinuria mean kidney is involved. Okay. So it's a direct question, easy question. Please go through my gastroenteritis, acute gastroenteritis note. It's a complication of diarrhea with a hemolytic uremic syndrome. Good-Pasteur syndrome, you don't need to know about Good-Pasteur syndrome for undergraduate level, but remember that there could be hemoptysis, blood coughing, and hematuria and Good-Pasteur syndrome. Hemolytic uremic syndrome, there's a triad. These are common MCQ. Again and again, they are asking about hemolytic uremic syndrome. There's a triad. Usually, HUS appear 5 to 10 days after diarrheal illness. Okay, they will be having 3 symptoms. 3 symptoms are acute renal failure, microangiopathic hemolytic anemia, thrombocytopenia. All those 3 are in this question. Okay. Then the nephrotic syndrome, usually in the nephrotic syndrome, they will having edema, proteinuria, and hyperlipidemia, but not hematuria. Hematuria is not common in nephrotic syndrome. It is common in nephritic syndrome. Okay. And post-streptococcus glomerulonephritis is a type of nephritic syndrome. There will be hematuria, but there won't be this convulsion, this anemia, all those things. It won't appear in post-streptococcus glomerulonephritis. And if they are going to discuss about post-streptococcal glomerulonephritis, they will definitely give about pharyngitis or skin infection due to streptococcus in the past. Okay, but there are no such keywords here. So it's not post-streptococcal glomerulonephritis. And renal vein thrombosis, in renal vein thrombosis, which is a complication of nephrotic syndrome, usually there will be abdominal pain. They have not told about abdominal pain here. So the answer is hemolytic uremic syndrome. Okay. Go through my nephrotic syndrome. Not as well. There are all the complications. Okay. The next question, 16-year-old female presents with ankle swelling for ankle swelling 2 weeks ago and red color urine. On exam, she had blood pressure of 140/95. Investigation revealed creatinine 98 is normal. Albumin 38 is also in the lower limit of normal. 24-hour urine protein is 1.2 grams. So she's having proteinuria. Okay. So what could be the cause for this proteinuria? The main issue here is proteinuria and hematuria edema. Okay, the three issues here is proteinuria, hematuria, and edema. Okay, here they are discussing about the nephritic syndrome. So go through my nephritic syndrome note. Okay, so nephritic syndrome, the for undergraduate level, if hematuria is given, usually they are going to discuss about nephritic syndrome. There are many causes for nephritic syndrome. Okay, there are glomerular causes, non-glomerular causes for hematuria. The non-glomerular causes are usually stone, tumors. Sorry. The glomerular causes are usually IgA nephropathy, any type of glomerulonephritis like minimal change glomerulonephritis, membranoproliferative, post-streptococcal. Okay, but you don't need to know about every type of glomerulonephritis. If you know about post-streptococcal glomerulonephritis, minimal change glomerulonephritis, and IgA nephropathy, that is more than enough for undergraduate level. They won't ask about other things. Okay, so in that sense, IgA nephropathy, it's a macroscopic hematuria. It means you can see the red color urine with the naked eye. You don't need to do the microscopic examination. That's much the severity of hematuria and IgA nephropathy. And it is also associated with upper respiratory tract infection. Okay, upper respiratory tract infection. And again, about minimal change glomerulonephritis. Minimal change means, according to words suggest there is no symptoms and signs. Minimal change, there is no symptoms. So there are, here in this question, there are many symptoms. So it won't be minimal change nephropathy. And membranoproliferative, you don't need this for your undergraduate level. And again, idiopathic also you don't need for undergraduate level. And post-streptococcal glomerulonephritis, here the keywords are missing. Post-streptococcal, usually it's a sudden onset gross hematuria, edema, and hypertension. But there should be a past history of pharyngitis, sorry, 1 to 2 weeks before the occurrence of hematuria, or 3 to 6 weeks after skin infection of streptococcus. But they have not given about pharyngitis or skin infection, so it is not post-streptococcal glomerulonephritis. So out of this, according to age as well, here they have discussed about IgA nephropathy. So answer is IgA nephropathy. Okay, go through my nephritic syndrome now. Okay, the next question. 9-year-old boy presents with fever, headache, gum bleeding, and oral ulcer for 1 week duration. On examination, he has multiple ecchymosis fractures and he is pale. There is cervical lymphadenopathy actually, and hepatosplenomegaly. White cell count is less, hemoglobin also less, platelets also less. Okay, there's a pancytopenia because all 3 cell lines are reduced. So, what the first step is management? They have not asked the diagnosis here. So, what's the first step management? I have already said, first step means the life-saving management. Okay, here, all the cell lines are reduced. But the most issue the child will develop is a sepsis because he is not having enough white cells. Okay, so, so to prevent the child from developing sepsis, First, you have to give prophylactic antibiotics. Okay. For that, start IV antibiotics, the first line. Because you can do RBC transfusion, bone marrow aspiration to find out the diagnosis. You can give granular site. All the answers are correct. But the first management, because as lack of WBC, the child is more prone to get infection and sepsis. Once the child got sepsis, you can't save the child. So for that, we have to give prophylactic antibiotics first. Then you can go for the to find out investigation to find out the diagnosis and other deficient factors. You can give that as treatment. So the first management is IV antibiotics. Okay. Uh, Next question. The child presented for routine immunization is having a history of defaulted treatment for a congenital heart disease. MOH wants to refer the child to the pediatric cardiologist. What's the best indicator for referral? These are common MCQs where you have to know when to refer a patient. It could be emergency, could be a MOH referral. I have given all those things in my notes. Okay. For that, in this, as the congenital heart disease, refer my CVS note. I have given when to refer child to a cardiologist. Urgent referral is needed if the child is having heart failure symptoms, pulmonary hypertension, or failure to thrive symptom. SAM, severe acute malnutrition, moderate acute malnutrition, like that. Here, out of these 5 answers, the loud second heart sound might depict pulmonary hypertension. So this could be answer to refer the child to the cardiologist. Harsh pansystolic murmur can appear in a small VST. You don't need a urgent referral. Thrill can appear in any heart disease, mild heart disease as well. So it is not needed. It's not mandatory, urgent referral. You can refer still, but the best answer is loud second heart sound, which depicts the primary hypertension. Poor hygiene, ejection systolic murmur, all those things are an issue, but still the best answer is loud heart sound. That's why I'm telling do plenty of MCQ, because this experience you will get only by doing more MCQs. Okay, here the best indicator is pulmonary hypertension depicted by loud house. You will refer the patient for all 5 indication, but the urgent indicator is pulmonary hypertension. Okay. And this trill, harsh pansystolic murmur will appear in small VST, ventricular septal defect. Okay, the next question. A 1-year-old baby admitted with irritability for feeding, fever for 3 days. On examination, baby is febrile, has small vesicular eruptions in circumoral area, buttocks, posterior aspect of the thigh, and so his throat appears red with similar lesions, but the most likely etiological agent. We have not asked the diagnosis here. They have asked the agent for the diagnosis. So you should know the diagnosis first. Without knowing the diagnosis, you can find out the agent, etiological agent, the microorganism. So here, what are the causes for vesicular eruptions? The main usual causes for undergraduate levels are hand-foot-mouth syndrome, varicella zoster, herpes simplex virus, molluscum contagiosum, and eczema. Out of this, here the child is 1 year, and there are these vesicular eruptions, buttocks, thighs, soles, all those things. Okay, so it's more favor towards hand-foot-mouth syndrome. There's a note for hand-foot-mouth syndrome. Go through that, and dermatology note. Okay, the hand-foot-mouth syndrome. It's usually it is caused by Coxsackie-A virus. There could be low fever, low-grade fever, non-pruritic vesicular eruption, which are painless, and it involves hand, foot, mouth, genitals, buttocks, and the management is mainly supportive. You don't give any antivirals for that. The mainly fluids, rest, and supportive management. You isolate the child. Okay. Okay, that's a hand foot. So the answer is Coxsackie. Herpes simplex, it's not the answer. Staph aureus, varicella zoster, it's not favor. Okay. Definitely you will get one dermatology SBA, If you know that dermatology, if you go through my note, that is far more enough to get that correct. Okay. 3-year-old boy has widened wrist, ricket rosary, ball legs. Go through my rickets short case note. He has very high alkaline phosphatase level with low serum. Calcium low, phosphate low, but ALP is high. ALP usually depicts destruction to the bone, placenta like that. Here, no placenta in 3-year-old boy. So it could be bone. Radiological, there are features of rickets. So after 1 month of treatment with alpha calciferol, they have given vitamin D as a treatment. But still, there is no improvement. So what's the most likely diagnosis here? The rickets here, he's having ricket and he's treated with vitamin D, but still there is no response. So rickets, there are two types mainly. There are hypophosphatemic rickets and hypocalcemic rickets. Vitamin D resistant rickets is a type of hypocalcemic ricket. And liver disease related ricket also a type of hypocalcemic ricket. Okay. Here, though in hypophosphatemic rickets, calcium will be in normal range or low, phosphate is low, but the parathyroid hormone level is normal. In hypocalcemic ricket, calcium low, phosphate low, but the parathyroid hormone is high because there's a lack of vitamin D. So if vitamin D is given, usually hypocalcemic rickets resolves. But hypophosphatemic rickets will not resolve if even if vitamin D, the alpha calciferol, is given. So the answer is hypophosphatemic rickets. You don't need a deep knowledge about this ricket. If you go through my note, that is far more enough. Okay. Okay, the next question. Baby born by emergency cesarean section at term is found to have tachypnea at 4 hours of age. The membranes ruptured 36 hours before delivery. So it's a prolonged rupture of membrane. Okay. The mother had temperature 39. So there's a maternal pyrexia. Baby cried at birth. On examination, respiratory rate 60. And there's a recession. So it's a most likely diagnosis. So go through my respiratory disease of newborn note. Here, there's a prolonged rupture of membrane. Usually, if there's more than 18 hours after rupture of membrane, and if there's a maternal pyrexia or dribbling more than 18 hours, or maternal UTI during delivery. So our working diagnosis usually, if there is these risk factors, our working diagnosis for undergraduate level is congenital pneumonia. Congenital pneumonia, usually it's caused by group B streptococcus and E. coli, and milk aspiration usually an acute thing. So it won't happen with this clinical scenario, okay? Because there are risk factors of infection. Persistent pulmonary hypertension of newborn, it's a term baby, emergency cesarean section. They have not told about any cardiac lesions here. Okay, so it's not persistent pulmonary hypertension. And pneumothorax, usually air entry is reduced in the affected side of the pneumothorax, and transformation can be observed in the side of the pneumothorax. These are the keywords they usually give. If they are going to ask about pneumothorax, there are no such keywords given here, so it is not pneumothorax. For undergraduate level, they won't ask in the gray area or black or white area, they will be asking. So if you know the characteristic keywords of each of the disease, that is enough for us to correct to get correct in single best answers. Transient tachypnea of newborn, usually soon after birth or within 6 hours of birth, the child will experience transient tachypnea of newborn. It is happening due to delayed resorption of the amniotic fluid. Usually soon after birth, amniotic fluid will go into the lymphatics from the organs, from the lungs. But if it persists in the lungs, the child will be experiencing tachypnea. And it usually resolves within 24 to 48 hours. So the answer is congenital pneumonia. Okay. The next question, the 5-year-old baby is brought to the lactation management center due to maternal concerns in inadequate breast milk. The birth weight was 3 kg. and had been on exclusive breastfeeding up to now. What's the best indicator of inadequate breastfeeding? Okay. So they have asked what are the feature of inadequate breastfeeding? Go through my breastfeeding and Gangaru mother care. No. Okay. Here, birth weight is 3 kg. Okay. But you have to look whether the child has attained adequate weight. So for 5-year-old baby, within 1 week of age, more than 10% weight loss is not normal. It is abnormal. So absent letdown reflex, it's an indicator of inadequate breast milk production, but not the indicator of inadequate breastfeeding. Breastfeeding means the child is feeding. Okay. If the milk production is less, absent letdown reflex depicts the milk production, the lack of milk production, not the lack of feeding. Passage of urine 5 times per day. You can't tell the times of urine. You can't assess the adequate breastfeeding with times of urine output and times of feces output. Okay, that's not a good indicator. Presence of jaundice could be a physiological jaundice. It could be normal or abnormal, but you can't definitely say it is due to inadequate breastfeeding. Presence of meconium in stools, you can't say it is definitely due to inadequate breastfeeding, because usually within 3 to 5 days, the child will be eliminating meconium, which is normal. Presence of weight of 2.5 kg. So within 5 days, the child has lost 500 grams. It is abnormal because more than 10% of birth weight loss. Out of 3 kg, 10% of 300 grams, the child can lose 300 grams in first week. But here the baby has lost 500 grams. So it could be best indicator out of this 5 answer for inadequate breastfeeding. Okay, there are other causes as well. Go through them in my note. Okay. The next question, 12-year-old girl, after adult tetanus vaccination, she was crying due to severe pain suddenly, and she became pale and collapsed, fell down. Peripheries were cold and sweating, pulse rate 50, reduced. What's the immediate next step of management? Here, what's the child has developed? Okay. It's an emergency or thing. So you have to find out whether it's due to anaphylaxis. Okay, because child had already got the vaccination. But here, adult tetanus, it's not a new vaccination for the baby, because from birth till 12 years, he has got more than up to 5 injections. And pentavalent vaccine 3, and then tetanus vaccine 5 year, and in 12 years, this is a 5th vaccine, tetanus. So it is not a new thing. So it's not, we can't consider this vaccine as an allergen. But still, let's look whether it's anaphylaxis or not. If it is not anaphylaxis, there is no point in giving IM adrenaline. Okay. So you have to find out whether it's anaphylaxis or if it is collapse. There are two chances for undergraduate level collapse. It could be a syncope or anaphylaxis. Okay. So you have to look whether it's anaphylaxis or syncope. Then only you can go for the management. For the anaphylaxis, there are criteria to say this is anaphylaxis. What are the criteria? Go through my anaphylaxis. No, there are 3 criteria. One is if there's a skin involvement with respiratory compromise or organ dysfunction or reduced blood pressure. But here they have not told any skin infection. Otherwise, there's other criteria. Exposure to a new allergen with 2 of the following, like skin or respiratory compromise or organ dysfunction or GI symptoms. Here they have not told about any skin or GI symptoms. So it is not anaphylaxis. So our next DD is syncope. Okay, now let's discuss whether it's syncope. Yeah, crying, severe crying due to pain. After crying only, he has collapsed and peripheries are cold, so blood supply is less. What is syncope? This is a transient ischemia to brain. Okay, so what's the management for vasovagal syncope? This is a vasovagal syncope. What is vasovagal syncope? It's a over activity of the autonomic nerve system due to prolonged standing or pain or prolonged emotion due to stress. These are commonly asked in your MCQ. You have to be thorough whether we have to differentiate whether it's anaphylaxis or vasovagal syncope. So here it is vasovagal syncope. You have to, for the management, you have to increase the blood flow to the head. Okay. For that, suddenly the thing you can do is ask her to keep her head lower down position so that you can increase the blood flow to the head. Then the child will automatically spontaneously resolve. You don't need this saline or these things. Okay. Okay. The next question. 3-year-old child was admitted with high fever, abdominal pain, loose stools. He had vomited twice and had low urine output. On examination, he was ill-looking and drowsy. Tenderness and guarding were noted on the abdominal examination. Tenderness and guarding are there. So it depicts any abdominal infection. Abdominal X-ray reveal multiple fluid levels. So gas under diaphragm. Usually multiple fluid levels and gas under diaphragm depicts the intestinal rupture. So what's the best combination intravenous antibiotics? So here the child is having sepsis. Okay. And the cause could be intestinal. Okay. So go through my sepsis note. For any sepsis in children, we usually go for cefotaxime or ceftriaxone because we have to cover gram-positives and gram-negative bacteria and anaerobic bacteria. Okay. And here, as it is due to intestinal cause, you have to cover the anaerobic bacteria as well. For that, we usually go for metronidazole in Sri Lanka. So the best combination is cefotaxime and metronidazole. Okay. So you have to thorough with this antibiotic as well. So go through my antibiotic sensitivity note. All the things are there in that note in a chart in an easy way. Okay. And the next question. 6-week-old baby brought to the emergency unit by mother due to forceful vomiting after feeding. He feels hungry and alert. There's a fullness in right upper quadrant. What's the diagnosis? Go through my pediatric surgery note here. Pyloric stenosis. What is pyloric stenosis? Here, there's a hypertrophy of the circular muscles of the pylorus of the stomach. Okay. So for that, there will be it's a sort of obstruction. Okay. So usually, the child develops the symptoms. There's a forceful vomiting, poor weight gain, but the child will be hungry until the child develops dehydration, leads to loss of interest in the food. These are symptoms of pyloric stenosis. Usually, it is more in firstborn boys, and it usually occur around 2 to 8 weeks of age. So this is fullness in the right upper quadrant as well. It's more likely towards pyloric stenosis. So this is the answer. For raised intracranial pressure, the child is alert. So the GCS is normal. So it is not raised intracranial pressure. Usually in raised intracranial pressure, GCS reduces. Necrotizing enterocolitis is usually happening in preterm babies. There will be fever, but they have not said about fever, and the child is alert, so it's not necrotizing enterocolitis. During atresia, there will be bilious or non-bilious vomiting few hours after delivery, depending on the site. And there will be double bubble appearance in the X-ray. These are the keywords, but they are not given those keywords for, that's why it's not duodenal atresia. And GORD, gastroesophageal reflux disease, we won't expect forceful vomiting. Here there will be vomiting. GORD, there will be normal weight gain, and URD is normal up to 12 months of age, and it resolves by 1 year because the child is taking solid food and the child is in upright position now most of the time. So GORD is unlikely. Okay. And next question. 2-year-old previously well baby girl was playing in the garden, presented a ward with sudden onset wheezing. She was previously well, now sudden onset wheezing. Something acutely has happened to this child. She's conscious and actively she's coughing. So what's the next step? The answer is next step management. Okay. Here, go through my foreign body inhalation note. Here, foreign body inhalation can happen in GI tract or respiratory tract. Here, it is respiratory tract because it has a sudden onset wheezing. Wheezing means respiratory symptom. Okay. So respiratory tract foreign body inhalation, the very first is you have to encourage coughing. Here, child is actively coughing, so you have to encourage coughing. That's the answer. But in a choking child, if cough is good, encourage cough. But if the cough is poor, you have to give 5 back blows and 5 chest thrust. If the child is unconscious, you have to assess the airway breathing circulation and you give CPR. You have to get the help from the anesthetist, ENT surgeon, like that. Go through my choking child now. Okay. The next question. 12-year-old child presented with myoclonic seizures and ataxia of 3 months duration, 6 months back. He was well and performing well at school. Okay. It's a only for 3 months he is experiencing abnormality. But since recently, his school performance dramatically deteriorated. And teacher complains of abnormal aggressiveness of the child as well. That's a problem in the brain. That's why there's seizures, ataxia, behavioral issues, and past medical history. That's insignificant, except there's a febrile rash at 18 months of age. That's the most likely diagnosis. Okay. Okay. Here, there's a brain issue. And there's a history of rash at 8 months of age. Okay, it's a bit, if you know, it is a question. And here they have discussed something about the motor disease, abnormality in the motor, okay, the movement of the child. So in the motor disorders, there are 3 types, which is needed for undergraduate level, but you don't need a deep knowledge. The problems in the pyramidal tract, which is the acute disseminated encephalomyelitis. It's an example. A problem in the basal ganglia can cause motor disorder like Wilson disease. Problem in the cerebellar area can cause motor disorder. But here, the child has developed a rash at 8 months of age. So Wilson disease, only brain is involved and there is no genetic keyword. The genetic familial involvement is not stated here. So it is not Wilson. Okay. And juvenile myoclonic seizure, usually juvenile myoclonic seizure, go through my seizure and epilepsy note. The learning is not impaired, but here learning is impaired, so it is not juvenile myoclonic seizure. Subacute sclerosing panencephalitis. Panencephalitis means most of the parenchyma is affected. What is this? This is the measles, the complication of the measles. 4 children out of 100,000 who develop measles will get subacute sclerosing panencephalitis 5 to 10 years after onset of measles. You all know measles vaccine is covered in MMR, which is given in 9 months and 3 years of age. So 8 months of age, there's a high chance of developing measles because the vaccine is given at 9 months of age. So the fever with rash could be a measles. So it could be a long-term complication or a late complication of measles, which is a subacute sclerosing panencephalitis. This is the most common MCQ they ask again and again for undergraduate level. So subacute sclerosing panencephalitis is the answer. Okay, Japanese encephalitis. There's no history of Japanese the mosquito bite like that in this question. Okay, the next question. The 4-week-old A positive infant. The blood group is A positive. 40 weeks gestation, a term baby, born to O positive mother. Mother is O positive. Experience hyperbilirubinemia, which require 2 days of phototherapy. So there's a severe jaundice in newborn. The infant appears apathetic and demonstrate pallor. There's anemia and grade 2 systolic ejection systolic murmur. Heart rate also high. That's the most likely diagnosis. So here there's a jaundice and anemia. So what are the I'll go through my neonatal jaundice, not indirect and direct. So the causes for the jaundice you have to assess this. Out of this, he's a 1-month-old child, and there's ABO incompatibility between mother and the child because mother is O positive and the child is A positive. Okay, there's no chronic disease, anemia of chronic disease. Usually, anemia of chronic disease, it won't resolve even with phototherapy. Okay, you have to treat the chronic disease. Then only the anemia of chronic disease, jaundice, hemolysis will resolve. Here, polystasis, neonatal hepatitis, they have deep jaundice, and they have not told about this obstructive jaundice in this question. So it's not holystasis. The obstructive jaundice features are dark urine, pale stools, and deep jaundice. They have not told about dark urine, pale stools. Okay. Hereditary spherocytosis also usually spherocytosis, there will be spherocytes in the blood picture, and phototherapy can the hemolysis, there will be hemolysis, but it won't be very severe in this 4-week-old child. Okay, and sickle cell with hemolytic crisis, usually it won't occur in 4-week-old baby. So that's why I'm telling the age, every word, keyword is important in a single best answer. It could be ABO incompatibility because you all know that there's A positive and B positive. ABO incompatibility where there is still hemolysis. Okay, so this is the answer. Okay, the next question. 1.5-year-old girl presented with symmetrical cervical lymphadenopathy and fever. Examination revealed hepatosplenomegaly and metal cervical lymphadenopathy. Her father is a Chena cultivator. He's alcoholic and hits her mother every day. She has a mark similar to cigarette burn in the axilla. What's the probable diagnosis? Okay. Here, the child is having lymphadenopathy and fever. So what are the DDs? Lymphadenopathy and fever. The DDs are malignancy, infectious mononucleosis, like that. It's not LMN, this is IMN, infectious mononucleosis. Sorry, okay. And hepatosplenomegaly, the DDs, it could be infection due to an Epstein-Barr virus, cytomegalovirus, typhoid, toxoplasmosis lymphoma, like that. Here, child abuse. There is a child abuse because there's alcoholic and hits mother every day. But she's having a mark like similar to cigarette burn in the axilla. They have not told it as a cigarette burn mark. They have told it as a mark similar to cigarette burn. So don't deviate towards child abuse. Okay, child abuse could be there, but cervical lymphadenopathy, hepatosplenomegaly, it is not due to child abuse. So child abuse is not the answer. Here you have to exclude the answer. Then only you can go for the correct answer. In some types of SBAs, you can directly get the answer once you read the question. Like the trisomy, Fatau syndrome, they like the question. In some of the SBAs, you have to exclude the answer. You can't come to a diagnosis just only by reading the question. Okay? So here also like that, you have to go through the answers, then only you can get. So child abuse is not the answer. Typhus fever. You all know, typhus. I go through my typhus note. Acute high fever will be there, myalgia, conjunctival suffocation, and this hepatosplenomegaly can be there. And the typhus, the main is scar, the lesion, skin lesion. So the cigarette burn like mark, similar to, it's not a cigarette burn actually. It's a mark like cigarette burn, could be a scar. Okay, so there are chance of typhus. Next thing, typhoid. Typhoid, there could be fever, dry cough. Initially, there will be constipation followed by diarrhea. There are no such raw spots, soft enlarged spleen. These are the features of typhoid. There are no such features given as a keywords in the question, so it's not typhoid. Infectious mononucleosis, it is a glandular fever or kissing fever, it's known as. So there will be fever, malaise, pharyngitis, lymphadenopathy, palatal petechiae, maculopapular rash, soft splenomegaly, hepatomegaly, but some of the keywords are missing, so it's not infectious mononucleosis. So in lymphoma, there's a progressive enlargement of lymph node, which is non-tender, soft to firm in consistency. And there could be hepatosplenomegaly, but there could be constitutional symptoms because it's a malignancy, loss of weight, night sweats, fever, but constitutional symptoms are not given in this question. So it's more towards typhus fever. Okay, go through this everything in my note. The next question, a 10-month-old baby present with itchy rash, mainly over flexus. He also has rash in the face, trunk symmetrically. He has exclusively breastfeeding up to 6 months. No family history of similar rash. His elder brother has bronchial asthma. Okay, there's a familial issue, familial asthma, and there's a rash. So it could be atopic dermatitis. Okay, he's also diagnosed to have atopic dermatitis already. Diagnosis given. Okay, so what's the early relieving management? Here, the main issue, what's the main concerning symptom is itchy. Itchy is the main concerning symptom. So you have to reduce itching first. For that, you can give sedative antihistamines. Okay? Okay, it is atopic dermatitis. So the main concerning symptom is itchiness. So you will go for sedative antihistamine. Okay, emollient is just moisturizer, but it won't reduce the itchiness. Avoid soap also, it won't avoid itchiness quickly. We have to reduce the itchiness. So that's why we go for sedative antihistamine. Topical steroids also, it won't relieve itchiness quickly. Okay, but antihistamine will quickly resolve the itchiness. Okay, the next question. 12-year-old girl was seen at the clinic due to ongoing recurrent abdominal pain for 1 month. 1 year, sorry, 1 year. There's a recurrent abdominal pain. Mother complains that she has on and off low-grade fever, alteration of vision, and joint pain. So multiple systems are affected. Abdominal pain, fever, eye is affected, joints are affected. So it's a generalized disease. On examination, she is so short also. And pre-pubertal each. 12-year pre-pubertal normal, but short is not normal. Diffuse mild abdominal pain was noted in the abdominal palpation. What's the most likely diagnosis? Here also you have to exclude. Here, the cystic fibrosis. What is cystic fibrosis? Cystic fibrosis means it's an autosomal recessive disease where chloride ion secretion is reduced and sodium and water reabsorption is increased, where exocrine glands, the mutation causing defects in the function of the exocrine glands. So the symptoms are usually age-dependent. In newborn meconium-ileus, these are this cystic fibrosis also commonly asked MCQ. Go through this in my note. Newborn meconium-ileus is the commonest presenting complaint. In infant, failure to thrive, steatorrhea, commonest symptoms. In a child, rectal prolapse. In old children, intestinal obstruction is the main symptoms because there is a sodium and water absorption making stools very hard. So there will be more GI symptoms. So there are no such GI symptoms given here. Only the abdominal pain is given. They have not told about constipation like that. So it's not cystic fibrosis. And Crohn's disease It's a inflammation, chronic inflammation in the gastrointestinal tract, in the entire gastrointestinal tract. There could be abdominal pain, chronic diarrhea, growth faltering. That's why the child is short, bloody stools, anemia, fever, anorexia, perianal symptoms, like that. So it's more favor of Crohn's syndrome because she's having recurrent abdominal pain, and there is abdominal pain on palpation as well. Abdominal migraine also will might present with migraine, like the migraine in the head. It's a on and off abdominal pain, but the other systems are not affected. Usually, there won't be fever, and the growth will be normal in migraine. But here the child is short, so it is not abdominal migraine. Sexual abuse, there is no history of sexual abuse in this question. And there's a fever. Fever is not usually due to sexual abuse. And school phobia also, she is experiencing for only for 1 year. School, if there is school phobia, it should have started when she started schooling, usually at 6 years. So it's not school phobia. So answer is Crohn's disease. So go through my inflammatory bowel disease, not Crohn's and ulcerative colitis. Okay. The last question. 5 years old female arrives in emergency unit with a 2 days history of fever, irritability, poor oral intake for the baby. This afternoon, her mother had difficulty waking her from a nap, and she also noticed appearance of dark rash in her extremities. She immediately brought her to the emergency unit. So you suspect meningococcal disease. They have already given the diagnosis. Sometimes in your question, they will give these things and ask for the diagnosis. So do plenty of MCQ. I would advise you to go through Sri Lankan final common MBBS papers at least around 10 years, because those are the things they are going to ask for you in an easy way. The final MBBS, the final government MBBS MCQ paper is a hard one, but they will ask the same points in your paper in a simple, easy, direct way. So if you go through, I have given that with the review, the answers and reviews, how can you get the answers for that in Sri Lankan papers. So go through them as well in your free time, because all the MCQs they give for ERPM exams are already appeared in the final common MBBS paper. So if you practice last 10 year final common MBBS paper of government MBBS paper, you will definitely pass. Okay, because those are the key areas, those are the key words they are using. So I have given those papers. I will be discussing those as well. Please go through them. Okay, and all of the following would be a contraindication. So lumbar puncture, except here the question is which is not the indication to delay lumbar puncture. Go through my meningitis note. I have given the indication where you might have to delay lumbar puncture, because those are the contraindications. The contraindications for lumbar punctures are the increase if there's a signs and symptoms of increase in intracranial pressure, or if the GCS is less than 13, or if the GCS is deteriorating and the child if the child is not the child is unconscious, or if there's a recent onset of seizure within 30 minutes of presentation, or prolonged seizure, or if the child is in shock, or if there's a focal neurological symptoms and sign, or if there's a local sepsis like intracranial suppuration, you will not do lumbar puncture. So out of this, which is not a contraindication for LP, this is a question here. Out of this, bulging fontanelle is not a contraindication, because bulging fontanelle can happen, can occur if the child is crying, or in a simple instances there will be bulging fontanelle. It will not depict the increased intracranial pressure in 5-day-old baby. So it is not the indication to delay LP. Okay. Okay, that's all for this discussion. Okay, thank you for listening. So if you need to join my classes, I will be doing all the clinical MCQ sessions or ski formats, short case, long case discussion, history taking sessions. So please, if you want to join my classes, WhatsApp me to this number. Okay, thank you for listening. That's all for this session.